Good afternoon, everyone, and welcome to the East Lane Corporation's session pertaining to pressure injuries. And of course, I would like to thank first and foremost East Lane Corporation, Mr. Ramil de Guzman, for inviting me and have you as a key opinion leader. And the topic for this afternoon is about recognition and management of early pressure injuries. This is my usual disclaimer, and the contents of this slide is mostly based on the recent NPUAP or NPIAP guidelines or the National Pressure Injury Advisory Panel. They are mainly for scientific discussions only and not for recommended off-label recommendations. Now, there might be some techniques and some procedures that are done by yours truly or other practitioners that I have shared, and this is mainly because it was one of the best practice guidelines currently used in our hospital. And we collaborated it or uh, we used it in coordination with the advisory panel guidelines, which is globally. If there are products mentioned, it is used for the purpose of the topic discussion only. Now, my objectives, of course, include to briefly discuss the updated definition and different stages of pressure injuries and other similar skin injuries, to discuss the different modalities and methods of prevention and management of early pressure injury stages on a nurse perspective, and of course, within the scope of practice here in the Philippines. As we all know, that the scope of practice here in the Philippines is quite different compared to the international because in here there are some limitations pertaining to wound management, especially doing debridement. And we all know that debridement is not used by nurses here in the Philippines, especially sharp debridements, but other types of debridement is okay. Now, in other countries, they allow nurses to do debridement or sharp debridement. I would also like to discuss the different modalities and methods of prevention pertaining to uh, pressure injuries, and of course, some of the management, and to also better understand the different gaps and misconception between pressure injuries and to other types of skin injuries as well. Now, according to the recent guidelines of the National Pressure Ulcer Advisory Panel, the terminology that is being used nowadays or currently is pressure injury, and it really clearly states that no one should use the term pressure ulcer already, to to go to move on. And pressure injury is the right terminology that should be used in the hospital, and specifically during the time that we document. No? And this is because of the definition. And the recent definition of pressure injury is, of course, an injury on a bony prominence of the patient's skin or body part, and which is in contact with pressure, friction, and shear. Now, it also accurately describes that some of the pressure injuries are closed and intact skin, so meaning there is no open skin affected, but it is still categorized as pressure injuries. Now, later on my slides, you can see that there are many additional stages pertaining to pressure injury and also some of the newest classification of it. So that is the main reason that the NPUAP changed the term from pressure ulcer to pressure injury. This is because of the affectation. No? So not all patients that has pressure injury has an open wound. Some of them may have a intact skin. Another change that they have done is to change the number, pertaining to the stages. Before they use Roman numeral numbers, wherein it makes a lot of confusions to other stages and also to other types of medical terms. And that is why they advise that the Roman numeral should be used in using the staging of the pressure injuries. Even the name of the National Pressure Ulcer Advisory Panel or the National Pressure Ulcer Advisory Panel has been changed. No? They changed the name of the society in accordance with the terminology of the pressure injury. So it's now National Pressure Injury Advisory Panel. And when it comes to the National Pressure Advisory Panel, the definition, just like I have said earlier, they change it from before, pressure injury was caused by pressure alone, no, on a bony prominent area. Unlike now, the recent guideline definition that pressure injuries is a localized damage to the skin and or underlying tissue as a result of pressure and in combination with shear and friction. Now, for patients who have light skin, it is redness. It may start as a redness. But for patient who has a darker skin tone, it may be or it may appear purplish or bluish. Now, we all know that it is always being connected or it is always being, you know, uh, point out to practitioners, especially to health to nurses when it comes to healthcare, that pressure injuries are caused by nurses, are caused by other healthcare professionals, and neglected their practice because of the quality of care that was given to the patient. Now, it has been discussed also by the panel and the consensus panel that not all pressure injuries are caused by negligence or caused by poor quality of care given by nurses. There are pressure injuries that will happen definitely and inevitably for patients because of their clinical and critical condition state. Now, this would pertain to the new category that was given by the panel and also the classification. Now, just like I said earlier, that pressure ulcer was the previous term. And before that, no, there is also another term that we are fond of using, the bed sores. So bed sore and pressure ulcer is the term that should not be used today. Instead, we should use pressure injury. And I was telling you about the current definition of pressure injury. Again, to emphasize that it is a redness or an injury on a bony prominence of the patient's skin, which is caused by pressure, friction, and shear. Now, the classification was done by the panel and have identified two, which is your avoidable pressure injury and unavoidable. Now, your avoidable pressure injury are pressure injuries that should not happen, meaning uh, it should not appear on a patient, or when it comes to medical liability, we or the institution is liable for having this type of pressure injury. And it is because of non-documentation, patient was not well assessed, the attending physician was not informed, the relatives and the family members are not informed of the injury, and there is no written and documented care plan pertaining to the patient's pressure injury, or meaning there is already an injury, but no one has made a step taking care of the patient or having done something to prevent it from getting worse. Unlike the unavoidable pressure injuries, these are pressure injuries which is inevitable. You have made your assessment, there is proper documentation, the attending physician knows about the pressure injury, team conferences are made, even the care plan is available and it is being presently managed well to prevent it from getting worse. But again, it is unavoidable because it's inevitable to happen, meaning whatever management or quality of care we give to the patient, it will really happen. It is because of the present condition of the patient. So basically, when the patient's condition decline, the body itself declines also, and the wound healing is affected. And but take note, no, to be able that it is to be able to categorize this as an unavoidable, this should still be disclosed to the patient's relatives, meaning kailangan nagpaalam pa rin or may nagbanggit sa pasyente and sa kamag-anak niya that this type of pressure injury will really happen. doctor or the main attending physician may disclose this to the patient. And then after disclosure of the possible and inevitable factors that may happen to the patient, because again, the patient may be at high risk of developing such injury, there should be an acknowledgement from the patient's relative. They have signed the document that they have been informed, they are being well informed, and they know that this thing will happen to the patient. And the health worker or the healthcare team is prioritizing the care. So meaning they are thinking and looking into the most important thing, uh, which will save the patient's life, instead of looking first with the patient's possibility of having an injury, a pressure injury, or patients already have pressure injury, but they are unstable at that time. It cannot be turned. That is an example. Now, when it comes to the different stages, there are actually 6 stages, and there are some new stages which pertains to the pressure injury. So we have two classifications already: stageable, unavoidable, and the avoidable pressure injury. Then when it comes to stages, we have suspected deep tissue injury, stage 1, stage 2, stage 3, stage 4, and your unstageable injuries. Now, I always emphasize to my lectures that when it comes to the pressure injury stages, so that we won't be confused, we should stick to the right definition of each stages and not to be intimidated with the size of the wound or with the size of the pressure injury. Because most of the time it is always mistaken because we see or we look at the wound size rather than the affected tissue. Now, if it is a pressure injury, and to not be confused when between pressure injury and to other types of wounds, a pressure injury is on a bony prominence. So you should know the anatomic location of your patient and the different anatomic location pertaining to the possible location that where will this pressure injury will happen. So basically, this is located on areas wherein it is bony and there might be a lot of pressure. And another thing is exposure to incontinence, which is your feces and urine. Now, your suspected deep tissue injury is an injury to your patient's skin or body part on a bony prominence, but the skin is intact. So when you see the patient's skin, or when you see that area of the patient, there is an intact skin. There is no open wound, but when you touch it, you can feel that there is a damage underneath. No? The area may be preceded by tissue that is very painful. It is firm, but mushy and buggy. So meaning it's so soft. Now, this injury, when it progresses, it turns into a blister. So it makes a blister formation. And then it may be exudate or it may be blood-filled blister. Now, when it progresses, it becomes big and then bursts later on. And then that's the time that it is already an open wound. And also, the category or the stage will be different when it bursts. So, till such time, it is considered or staged as your suspected deep tissue injury. Your stage 1 is a mere or skin redness or a non-blanchable airness on a localized area, usually on a bony prominence of the patient. So again, there's no open wound. It is an intact skin, but there is still redness. This type of redness is make always makes the health workers confused, no? And when it comes to staging, but not only to staging, but documentation. So most of the time, it is being practiced, no? Traditionally, that when it is only a redness, they don't document it. Wherein it is very important that you document it on the earliest possible time, so that we can already plan and create a program for that patient. Your stage 2 is a partial thickness skin loss, no, on a bony prominent again. So your 1 is no open wound, no intact skin but redness. Stage 2, partial thickness loss but there is no subcutaneous fat involvement. No. Your stage 3 is a pressure injury wherein there may be depth, no, and then mayroon na siyang thickness loss, no, full thickness loss of the tissue or the patient's skin, but there is no involvement of your muscles and your tendons. There is only subcutaneous fat involvement. So there is depth, no? But there is no involvement of the muscles, the tendons, and the fascia. But there is subcutaneous fat involvement, subcutaneous tissue. So your stage one is redness, stage two is partial thickness loss, stage three is full tissue loss, but there's only the involvement of your subcutaneous fat or subcutaneous tissue. Your stage four is a full thickness loss wound with involvement of the muscle, the bones, and the tendons. So meaning you can see the bones, you can see the muscles, and you can see the tendons when it comes to this type of pressure injury. There may also be a tunneling, and there can also be cavity, to your patient's pressure injuries. Now, stage one, redness, two, partial thickness loss, three, partial full thickness loss, but only subcutaneous fat involvement. Stage four, full thickness loss of the tissue, but there is involvement of the bones, the muscles, and the tendons. Now, when it comes to your unstageable, it is a type of pressure injury wherein it is covered with eschar, 80 to 100%. It may be eschar or it may be your slough. Now, look at the apple. You can see that it is fully covered by a candy or a covering. It is also same, no? I would like to say it that it's almost the same with your pressure injury wherein it is covered with 100% of necrotic tissue. Now, that's why it is unstageable because you cannot see the true depth of the wound. Now, till such time that this necrotic tissue or this sloughy tissue is removed by a surgeon with a debridement, then see the true depth of the wound, then that is the right time for you to change the staging of the pressure injury. It may be stage 3 or stage 4. But until such time that the eschar is not removed, the category or the stage is unstageable. There are also some pressure injuries that are added to the guidelines wherein it is called your medical device related pressure injuries. Now, this type of injuries is avoidable, no? Meaning we can be liable or there may be a problem on the care that is given to the patient. Number one, if we use these devices too long, as advised by the manufacturer, or if when these uh, devices is attached to the patient and causes friction and improperly placed to the patient or improperly removed, and then this is the one that causes the injury. So it is called your medical device related pressure injury. It may not be due to the medical device, but it is the practice that is the problem. So it is avoidable. So this is the published study that I have done last 2017 pertaining to the incidences of self-extubation and of course medical adhesive related skin injuries and medical device related pressure injuries to the critical care areas wherein it is very common or most of the patients there are at high risk. Another type of pressure injury that is added to the recent guideline is your mucosal membrane pressure injury. Again, this is a avoidable pressure injury wherein because of the prolonged use of the devices, wrong attachment of the devices are attached which is too hard or too narrow, or it can be too strong or too tight, upon application. These injuries might happen, but it is not external, no, it is internal. So meaning inside the patient's mouth, which is in the mucosa, the redness or the tissue injury happens. No? And again, you can see there an example is an endotracheal tube and a nasogastric tube. So very common that it happens on the lip and at the nares. Another type of pressure injury stage is your Kennedy terminal pressure injury. Now, this type of pressure injury was added on the list and added on the guidelines, which was discovered and named after the nurse who discovered it. It is a pressure injury wherein it is categorized as unavoidable. It will happen, no? And then this is because of the present condition of the patient. Most patients who are on a do not resuscitate status, and then all of a sudden, and because of their status or the condition of the patient, most of the time, the patient's relatives decide to take off the some of the uh, treatments. and stop some of the procedures that is going to be done to the patients. This is because they decided to just have the patient's condition on a natural flow or natural. Sometimes they would just tell them that let the patients rest. So that's why they're asking for the discontinuance of these treatments. No? It may not be better for the patient. So definitely, like I said earlier, because the condition of the patient's body declines, no, and it will be followed by your skin. So the injury starts as a redness or a dark pigmentation on the buttocks area of the patient, and then within a fast time of 24 to 48 hours, sometimes it may be lesser, that this injury would appear. So the redness initially, and then later on, you will see a rapid change in the tissue wherein it turns into a necrotic skin already. Now, pressure injury, always remember that your stage one and your suspected deep tissue injury is a intact skin. So there's no open wound, but your stage 2, 3, 4, it's an open wound, it has an open injury, and it may have depth. But again, most of the time we still get confused between pressure injuries and also other types of skin injuries, just as the same with incontinence associated dermatitis. So what is the confusion all about? You can see here on the images on the slides that your stage 1 and your IAD almost looks the same. So take a look at the picture, take a good look at it, and then think of the differences between the two. Think of the differences. Just like this one, your stage 2 pressure injury, like I said earlier, partial thickness loss. Yes, they have both partial thickness loss. No? But what makes them different from one another? And you look at the IAD and versus your stage 2. Your stage 2 location of the injury is very confined on an area, no, and the redness also, wherein the area that there is pressure. Unlike your IAD, you can see that the redness is, or the appearance of the skin is like a burned skin, no? And wherein it covers a larger surface area, not only on the pressure point of the patient, no, or the area where the patient has a pressure point, but you can see that covers a lot of area already. Now, IAD is an injury of the patient's skin that is caused by incontinence, so meaning prolonged exposure of your patient to urine and feces, no, that would cause this injury. And it happens to the extremes of age, meaning um, patients who are young, which belongs to the neonates and infants, would most likely have is or may have a high risk of having this type of injury. Another is, of course, our elderly patients. No? And this is because of their fragile skin. And most of the time, these patients or these ages, they use a lot of diapers, no, within the process. And these diapers are sometimes are the one who cause the injury to the patients. That's why we always emphasize that the changing of diapers must be done every shift as soon as possible or as much as possible. Change diapers as soon as possible if it gets soaked by feces injury. Now, another difference between the two, your incontinence associated dermatitis is a top-down injury, meaning the injury may come from the top, irritating the skin on the top because of the frequent incontinence that happens to the patient. And then later on, it will be eating down your tissue and will go down to your undamaged skin. And it will be the start of the injury. Unlike your pressure injury, it is a bottom up injury wherein the injury starts at the bottom, uh, damaging the tissues underneath, and then later going up to the surface of the skin wherein it will burst and become an injury. These are some of the most common factors that would most likely be confused of, no? Or you can see that they're almost the same. But look at the incontinence associated dermatitis. It is urinary and fecal incontinence. That's the cause. And if it doesn't have any urinary and fecal incontinence, it is not IAD. It may be other types of injury. It may be pressure injury, but still doesn't say that it is pressure injury. So when you look at the wound, make sure that you assess it very well. Pressure injuries, on the other hand, you can see that there is just friction, pressure, and shear. No incontinence. No? There is no problem with the feces and the urine. But will my IAD turn to a pressure injury? And I would say to this that yes, it can be. It is because incontinence produces or make the patient's skin, the affected tissue, exposed to moisture for a longer period of time. And we know that when your skin is exposed to fluids or moisture, excessive moisture to a long period of time, it can be macerated. There can be a high risk of having such injury. And then again, because it is in combination with friction and shear on that area, there would be a chance that your IAD would definitely turn to a pressure injury or in combination, or they can be both. Now, what are we going to do as a health practitioner or nurse? Basically, the most important thing is proper documentation and assessment, knowing the anatomic location of the origin, the redness or the wound. So I would suggest that when your patient comes from other institutions, make sure that you have checked the patient before clearing them from the emergency room and then bringing them up to the ward. This is to identify patients who had injuries which is home acquired or community acquired versus patients who had the injury into the hospital. Now, nowadays, this always happens, no? And because some patients, when they're or some relatives, when their patients already contacted or had pressure injuries in the hospital, they will never pay the bill, or they would contest it that the injury was caused by the hospital and the practitioner. Sadly, they always point to the nurses and do not pay the bills, or sometimes charge the bill to the nurse in charge, which is very sad. So planning also would include involvement of a wound care team, the primary physician. So in here at our institution, definitely if the patient has 2 to 3 doctors, there should be a regular team conference meeting, and the injury of the patient must be disclosed to them, so there will be no secrets, and it may be much more better for them to understand later on. An ostomy nurse is also essential, and or an enterostomal therapist, just like me, a physical therapist, occupational therapist, and a lot more of specialists that needed care or may be referred to the patient. This is again because wound care is multidisciplinary, meaning you are not the only one who has to take care of the wound. It should be a team that would take care of the wound. This is the basic process flow for patients who has a pressure injury. And then you can see here that we separated this process flow is being followed by our nurses on the general wards. So if they see the patient is at high risk, stage 1 and stage 2, there is already a basic independent nursing care available guide for them to check. So there's no need for them to call the doctor or to call the attending physician. When it comes to what dressings are we going to use, what solutions are we going to use to wash the patient's wound, wherein it is already there. And it can also help us identify patients who will be having a high risk of having such injury. And then it would tell us when to reassess the patient. So sometimes, or normally, if the patient is at high risk of developing, it can be a day or every shift reassessment. Moderate risk every 3 days, mild or low risk, it can be 7 days, every 7 days reassessment. Now, if your pressure injury belongs to stage 3 for unstageable and other complex wounds, it must be referred to the attending physician, and then the attending physician must decide to refer the patient. If the attending physician is non-surgeon, the attending physician must refer the patient to a surgeon for proper surgical evaluation. So there may be a need for surgical debridement or other types of debridement if the patient is not amenable. This is the common dressings that we use, and this is included on our protocol, wherein for stage 1, it used skin cleansers, moisturizers, oils, no, lotions. In stage 2, skin cleansers, foams, hydrocolloids, fibers, transparent films, tool dressings. IAD, you need barriers, cleansers, zinc oxide, no? And of course, your medical device related pressure injury, wherein it states proper medical device selection on application, removal, or how long will it take the patient. No? Those are the basic things wherein you don't need to ask the doctor from time to time because it's already an independent nursing action. Second, the dressings that are being advised are over the counter, meaning the patients themselves can buy it outside or buy it at the hospital. So they can use it freely. So why need uh, why need to wait? Or in you can already do something for the patient. And most of the time, because of waiting, the nurses are being blamed for prolonged turnaround time. So masyado daw matagal bago dumating yung nurse. Wherein nag-iintay kasi tayo ng order ng doktor, no? Now, when you look at this slide, you can see that at the bottom, highlighted on red, that a good turning schedule is still the best practice because whatever dressing that you use, whatever device you use to the patient, it will not heal if you will not turn the patient because of the circulation on that patient's body part wherein it has a pressure injury. Now, Smith and Nephew, distributed by Eastland, already has developed different types of foams with different sizes, which is applied to different body parts in a very easy application or very user-friendly way. So we also use these foams not only for wound care, but also for patients wherein we need to offload their body part like the heel, the bones, the knees, and they are very useful, unlike your conventional foams, wherein you need to cut a lot of the foams. And sometimes when you get a mistake, you throw the foams, wherein it's very expensive and the patient will have to buy another one. We also used a turn clock or a patient turn clock, wherein it is a poster placed to the different rooms of the patient. And then you can see there on the third clock the different position of their patient in an hourly or in every 2 hours. No, and because of this, we have increased the patient's awareness, not only the patients but their relatives' awareness pertaining to pressure injury. And if there is a time wherein the patient is still on a different or in a wrong position, they can call the nurse in charge to help them when it comes to turning or repositioning the patient. Now, it is important that we get them involved, no, the patient's relative, and if possible, the patient themselves because it would greatly affect the care when they went home. So, kasi pag uwi nila, sila yung mag-aalaga. Dapat alam na nila yan. So, it will be included in your home instructions. Now, the form on the right side is a form wherein it has a basic process flow that the nurses can follow. So, it will be easier for them to do uh, procedures or nursing functions wherein it is advised on the patient process flow. So, it is a guide for them. Now, the National Pressure Advisory Assessment Tool also have a different category and stages wherein it says mild, moderate, no, so or severe stage of for patients who are at high risk. Now, it is also a good tool, no. The one that we use is the Braden scale. It is a very good tool for this type of assessment. I would also advise the institution or your practice that surveillance and monitoring is also must be done, no. This is to identify patients who had pressure injuries that are community acquired versus hospital acquired, because sometimes the patient's relatives would tell you that they only had the wound here at the hospital or in your institution wherein they already have that type of wound when they're at home. So they're putting the blame to the healthcare provider. Most of the time when they have problems when it comes to paying, no, right? If you have such tool, it would really decrease this type of injuries or up to none, no, definitely, because it's very straight to the point and transparent. And then you can just tell them that during your admission, the patient already had a wound or a pressure injury before the hospital. And it is well documented on your assessment and surveillance tool. This is the basic progress form that we use, wound progress form or assessment form that we use. for our patients in the hospital, no? And you can see that it's very easy to fill up. You just have to tick the boxes. No need for long narrative documentations. And there are different images of the patients, front, back, sides, wherein you can just put a mark onto where the wound is. So sometimes using very highfalutin medical terms would sometimes make me confusions, or sometimes it's a wrong term that is being used to the patient. So, and most of the time, the nurse in charge, which will be on the next shift, will just copy the documentation that you use. Now, this form was developed by different hospitals. Mainly, the Philippine Wound Care Society was the one who developed this form, and they urge uh, or they advise other hospitals to use the form as well, because this is a collaboration of the different institutions when we are making this form, no, which is national, going to be used national, or can be used by anywhere. Planning must also include the use of the different alternating air mattresses, no, and identifying the different pressure points of the patient wherein there is pressure. Now, I would not advise the use of the egg crate mattress anymore because they are too soft, no, and could not really offload your patient's body part, unlike this alternating air mattress. And it is advisable for patients actually who are also bedridden, or sometimes patients who have unstable vital signs where interning is not possible. So these alternating air mattresses do the turning or repositioning of the patient automatically every 10 or every 15 hours. They inflate automatically, they deflate automatically as well. Offloading devices such are your wedges, pillow, turning sheets, and heel mattresses or heel protectors is also very useful. But I also would tell and recommend that there is no need actually to buy expensive devices like this. And sometimes your pillow and blankets are enough as long as it serves the right purpose. But again, it cannot really replace this type of devices, but they will be very expensive for some. When it comes to turning, most of the time, if the patient cannot be turned 90 degrees, the turning is not done. So yung healthcare provider natin, hindi niya to-turn yung pasyente kasi hindi niya ma-tolerate yung 90 degrees. Wherein, there is what we call the rule of 30 degree, no? Wherein repositioning your patient not more than 30 degrees or just 30-degree angle is enough to prevent patient's pressure injury, and it is enough to give proper offloading for your patient. No? And also, do not raise your patient's head part more than 30 degrees, especially if they have attached ventilators. And it's because of the sliding of the patient. And again, the sacral area is very sharp. It will produce a sacral shear on that area. Do not use latex gloves in water as an offloading device. There is actually no scientific and evidence-based studies pertaining to this. Yes, it is because of the soft and cold or cool temperature of the gloves. But again, sometimes they put warm water there. And the danger is, no, what happen if the latex gloves with water accidentally burst or pops? No? And then the area that you want to offload is exposed to prolonged moisture or to water, wherein it will be the cause of pressure injury in the future. Another thing is that most of the time, these latex gloves, and most people are very sensitive to latex gloves, no, wherein it causes redness on that area, and it masks the real assessment of your patient, wherein we thought it's a pressure injury because there is redness, wherein the real issue is the patient is having allergic reaction to the latex glove that is being used or placed on that part. This is a 5-point prevention tip for patients and also for healthcare workers on proper taking care and prevention of your patient's pressure injury incidents. So changing the position 2 to 3 hours, or mainly as advised by your attending physician, having the proper hygiene, proper nutrition, and of course, application of hyperoxygenated oil or your Sanerin. on that bony prominent area. This is again to increase the microcirculation and prevents dehydration on patient's body part. We have been using Sanrin for quite some time now, and it is very, very effective. Now, when it comes to nutrition, I advise that your patient be referred to a dietitian or nutritionist to promote better nutrition to the patient, thus promoting good healing, good wound healing for your patient as well. When it comes to hygiene, I forgot to tell you that as much as possible, avoid solutions that are too strong, no? That may dry the skin or might irritate the skin. Just use soap and water. It is very, very helpful as well, especially on the perineal area. Soap and water and wash the area thoroughly so that the excess feces and excess urine will be removed from that body part. Now, mattresses and pillows, just as like I said earlier, that it doesn't really necessarily need to use pillows that are too expensive or turning sheets that are too expensive. But again, if you have the right financial support from your administration, these devices can be very, very helpful when turning your patient in preventing injuries to happen. Now, remember that when you take care of patients with pressure injury or patients that has wounds, do not only focus on the wound itself. So also have to take care of the peri wound area or the skin on the sides of your patient's wound, no, or the surrounding skin. This is to prevent the wound for getting worse or getting larger. And basically, Sanrin is an effective tool when it comes to this. And we also use different offloading devices when it comes to taking care of the surrounding skin of the patients. Now, during the pandemic, there is a lot of device-related pressure injuries, and these are mostly caused by PPE. And this is because of the following, no? Prolonged use of medical devices used to COVID patients, prolonged use of medical devices with strong adhesives or not being washed well or taken off well, prolonged exposure to moisture and incontinence issues, patient's position to prone position on a long period of time. No? And this is because the vital signs are very unstable and then they have to be in a prone position to promote good lung expansion. But again, because of the devices, they mostly get medical device related injuries. So another thing is limited turning and positioning of the patient. This is because of the unstable condition. And now tips that I would say, especially for COVID patients, is that if there is a proning pillow that you can use as to the patient, it is very useful. And another thing is if you have a foam dressings or dressings that can use on the patient's skin or facial part, wherein it is the one that is in contact with the device that is going to be attached. It will be the one who's going to offload, or it is the one that is in contact with the patient's skin and not the device that you are going to attach to the patient. Tips, I would always say that even if whatever your patient's condition, if they are bedridden, wheelchair bound, or even an ambulatory patient, proper turning and repositioning and of course mobility is advised, or it is a good measure to prevent pressure injury to happen to your patient. And it is also best to use mechanical assisted devices for patients who will be having pressure injury or patients who are with pressure injury. Uh, Make sure that the team is well updated and informed, especially when you create a assessment tool so that it will be effective, no? Especially when filling up the forms. And it is also best to know your dressings well, which is you should always identify the dressings that is available in your institution. No? And most of the time, kasi we are having problems of advising patients to use dressings wherein when they go outside, no, it's not available. So it's best to use dressings to them that's available outside or widely available outside so that they can get them easier. a good assessment and documentation for better communication between the team members, healthcare workers, and also the patient and relative is very effective. And consider to treat patients wound in a multidisciplinary approach. We always say this in the society that do not treat your patient by yourself when they have wounds. It is a multidisciplinary approach so that the patient's wound will heal faster, despite of the factors that will delay healing to your patient. Now, of course, everyone, no, everybody uh, can do wound care as long as you really know the right principle and proper guidelines when it comes to managing the wounds. But always remember that you can do anything but not everything. This is to give emphasis for nurses, especially that in here in the Philippines, we still have to stick on the limitations of our practice and go on to the nursing law on what is the extent of our practice here in the Philippines and the right guidelines pertaining to patients taking care of wounds. And we don't want to happen in the future wherein we are the one that is being blamed because we did something that we thought that can help the patient, but unfortunately, it is the one that made the wound worse. So collaborate and always coordinate with the right person, especially your doctors, the attending physician of the patient. I think that would be all. And thank you very much for your attention. I think there will be questions to be entertained later. Again, thank you very much.